afternoon. My name is Dessalegn. I'm so happy to be here and to connect with fellow scientists working on the same field. Today I'll be presenting some of our part of my work for my PhD on contextualizing family dynamics in psychosis care. Okay. So first I will give you a background why we are interested in studying this topic and what the historic background look like, what are the motives behind this topic and how. Okay. Then I'll discuss about what the methods that we use to approach this exploration, then the findings and the future work also. I'll be explaining that. To give you a little bit of background, psychosis is a very complex and often chronic severe mental illness, significantly contributing to the global burden of disease as manifested by the high mortality and morbidity around psychosis. While early intervention is shown to be effective, but most of the focus has been on pharmacologic treatment. But research, even in our setting in Ethiopia, shows that comprehensive kind of intervention is needed that targets what matters for people with psychosis. And to make things worse, relapse is a very challenging task in the psychosis care, because with each relapse the chance of getting another remission is getting harder and the quality of life also worsens. So relapse prevention is a major task in the management of psychosis, but we only have few areas to actually act. For example, family dynamics is one of the few modifiable risk factors to prolong remission and prevent relapse. When I say family dynamics, it is widely studied in the Western setting. Especially expressed emotion is a very widely known psychosocial construct, and it has been shown as it's linked with relapse, and it is one of the evidence-based psychosocial predictor of relapse, but it's only been derived from studies from Western setting, and its applicability in non-Western setting is questionable, because expressed emotion is all about the attitude and behavior of family caregivers towards their ill relative. And if you see, attitudes and behaviors are usually culture bound, and they tend to vary from place to place, from population to population. So numerous calls have been made to researchers to work a more grounded contextual evidence, because family caregiving is everywhere, and it is much more profound in non-Western settings like Ethiopia. And there is also a growing interest to shift to shift mental health care into community-based care, as historically institutional care is linked with abusive practice. So there is an urgent need for evidence on family dynamics and what the family emotional environment look like in non-Western settings. So the objective of our study is to identify the key features that are relevant in our setting, the salient family dynamics, family communication and involvement features in our setting, and then from these insights we seek to develop a contextual measure of family dynamics. So to achieve the objective and to get a more contextual and grounded evidence, I did a 9 months ethnography in both rural and urban areas in Ethiopia. And I spent approximately 30 to 40 hours with 14 families. And the participants were selected using local gatekeepers who live on that area. And once this data is collected and analyzed, multiple expert group meetings were conducted to draw items that are relevant to our setting. And once the scale is prepared and developed, further pilot and validation studies were also conducted. So the thematic analysis, after the thematic analysis, I developed 3 themes to describe the nuances of family dynamics in our context. The 3 overarching themes are duty to care, communication landscape, and struggle for equal citizenship. So I'll go through one by one. So when we say duty to care, it describes the ingrained inherent responsibility families feel towards their ill relative, and it has moral, social, and practical overtones to it. But through this financial and emotional sacrifice, there will be care paradox that come with huge involvement in the person's life, especially if the family is struggling with limited resource. They have to strike the balance between providing emotional and basic needs support and also fulfilling the household subsistence needs. So during this challenge or struggling to balance, sometimes subsistence needs are more important to the family than attending vocational and other emotional needs of the person. So there will be only focusing on the functional way of interaction than or at the expense of deep emotional exchange. And when emotional exchange or deep emotional connections are not around, the person would be isolated, or some over controlling measures are also widely apparent. And these over controlling measures like restraints or neglecting in the family discussion, family decision makings, these over controlling measures are not actively condemned by the community, which raises a very serious ethical question. Actually, the community also, in one way or another, reinforces these management strategies as they are also the most obvious and practical one. When we see their daily conversation and communication, conversations tend to focus on maintaining stability and homeostasis than taking a risk to achieve a higher level of wellness. The families tend to manage symptoms in a conservative way, where they decrease their voice, they modulate their tones so that not to upset the person. The other difficult thing and the other cross-cutting issue is all or none view of wellness. The person is considered either fully stable or ill, so the middle gray area is usually forgotten, which takes away the chance where the person could have gotten by the incremental connection and the incremental recovery. So this all or none view of wellness is very problematic because it also has implications in their inclusion and citizenship level, both in the house and as a community setting. Usually, while they are living with their family, there are dissatisfaction, resentment, pity families feel towards their ill relative. But in contrary to critical comments that are widely expressed in Western setting, these negative emotions are not spoken not outwardly spoken. They are expressed in some subtle ways through their daily engagement in the family, what kind of the kind of tasks these people are given in the house, which are usually very mundane and trivial tasks. The other, which is also indicates they have very restricted role, and their opportunity for a higher level of wellness is limited because of this.
You have 2 minutes.
The other reason, the other finding is there is a struggle for equal citizenship, because perception about wellness is a very strong factor that shapes their inclusion within the family. So once we identified some of the relevant factors that are important to people in our setting, we draw items from these ethnographic insights, and we developed a scale to measure family dynamics within the house. So the next step is to develop an intervention that builds upon the positive or helpful ways of family communication and modify or limit harmful ways of communication. And also we are seeking to test the predictive validity of the scale we developed based on our work. Finally, I want to thank my supervisors for helping me work on this very important project, and also our anthropology consultant, Dr. Alex, and the SCOPE project, which I'm part of, which is doing a great work. And SCOPE is studying recent onset psychosis in Ethiopia. So it's a 5-year Wellcome Trust funded project, and I'm part of that team. Thanks so much for listening.